So thank you. This is not a boxing day, but this is just a scientific day. So I will focus on the facts because I'm really on evidence-based medicine, but the ProTech is for the hemodiafiltration. First, to understand what is different between what we are talking about, online hemodiafiltration or expanded hemodialysis. At the end, on the left side, you get what I call external hemodiafiltration. This is a way to control what you are doing. On the right side, you get internal hemodiafiltration, which is a way to do something without knowing what you are doing. This is a different story. And the second aspect is, of course, looking on level of evidence. So that means evidence-based medicine. I don't want to go on the detail, but we have to consider all facts. So the facts which are proved by science, okay? And I will come to this point. So where do we stand today? So there is HDX on one side, expanded hemodialysis, and on the other side, hemodiafiltration, clinical performances, secondary outcome, primary outcome, potential risk of the technique. So if we start with the expanded hemodialysis, and then this is just a review of literature I made. So just on the left side, you get the number of trials, 21. Since 2016, only almost 400 patients. What they show, if you compare expanded hemodialysis to high flux, there are, of course, superior instantaneous clearances for urea, phosphate, uric acid, beta-2M, light chain, and so on and so on. So the expanded hemodialysis versus high flux, there is a potential for, I would say, superiority. Now, if you compare expanded dialysis to hemodiafiltration, at the end, you will see in a minute, I will show some element. HDX is superior to high flux in clearing solute, but at the best is comparable to hemodiafiltration. But the point is, of course, in hemodiafiltration, depending on the convective volume you deliver to the patient. Now, if you take a very pragmatic study coming from Spain, Maduel, and this is very interesting, it develops this concept of solute global removal score. So this is percent of reduction with 6 markers from the low one, low molecular weight, to high one, with a ponderation which is albumin loss. And then if you look HDX on the left side, and if you look hemodiafiltration on the right side, depending on the filters, you see that it's almost either equivalent or superior every time. So for the same patient, in the same condition, there is no beneficial effect. Now, again, a few studies, and this is, just remember numbers of patients, 43 patients. So they compare hemodialysis to HDX in this case on inflammation markers, CRP, beta-2M, and some other markers. So high flux MCO, so at the end, there is some beneficial effect, but I will show you in a minute. There is some beneficial effect in some specific markers of inflammation. No beneficial effect on CRP as compared to the regular high flux, but already a trend, albumin is decreasing, okay? Then if you look on the study, at the end, what they show from some free light chain, kappa or lambda, TNF alpha, this is some positive aspect for the MCO membrane. So there is a reduction. Now, I will show in a minute what's happened with the albumin. And you see the albumin is declining. So at the end, within a few weeks, there is a decrease of the albumin by 1.5 grams. Now, focusing on the albumin loss, this is identified for the medium cutoff and super high flux, because if you go to Japan, they call that super high flux. And this is a lot of systematic review showing that all the study trying to show some reduction of the albumin. So at the end, you have to be very careful. This is an associated risk with this element. Now, if you compare different type of outcome, age-related quality of life, there is only one trial, 49 patients, showing that at the end, HDX tend to improve physical component and reduce pruritus. So limited studies suggest that maybe HDX may improve quality of life and reduce pruritus as compared to hemodialysis. And if you are interested by the primary outcome, which is clinical endpoint, only 2 studies. So that means one is coming from South Korea, cartoon, and the other one is developed, it's ongoing in Spain, MOTHER study. The first study did not show any beneficial effect on a cardiac. So 80 prevalent dialysis patient, in this case is 550 patient. So no significant differences in cardiovascular endpoint, and very curiously, coronary artery calcification score increased in HDX group. And the mother study was presented at as interim, I would say, analysis last year in ERIDTA, showing that at the end, preliminary suggests there is no inferiority, not superiority, but no inferiority. Now, if you move to hemodiafiltration, and almost hemodiafiltration was developed 40 years ago. Now, we know that we had a randomized study in Europe. Unfortunately, that's the point. Only one study, the ESCHOL study, was showing positive impact on the primary outcome on the mortality. Then the IPD, individual patient data meta-analysis, developed as a collaborative cooperation between these four groups, shows that at the end, if you go back to the data set, complete what you miss, there is a beneficial effect for the hemodiafiltration with a reduction of all-cause mortality and cardiovascular mortality already. And that was triggering the study which was reported 2 years ago, the CONVINCE study that showed in a large set of patients, more than 1,400 patients, that else, I would say, hazard ratio, so meaning for all-cause mortality, is reduced by 23%, almost equivalent to Fear-Renon study. So that means there is a confirmation, not only, but also from health-related quality of life, looking on a very specific tools, the PROMISE, which is the first time that you have a continuous monitoring of the patient-reported outcome for the patient. There are some beneficial effect on social participation, cognitive function, fatigue, and so on and so on. So there is a beneficial effect. And then the last study, which was published a few months ago, or a few weeks ago now from the Lancet, updated individual participation data meta-analysis with more than 4,000 prevalent patients, showing that mortality is reduced by 16%, cardiovascular and cardiac mortality by 33%. This is the highest level that you can show. And then not only, but this is clearly linked to the convective volume. So more you develop and more you give to your patient, and better you preserve the cardiac, or you reduce mortality. This is why measuring what you are giving or delivering to the patient is very important. So what is missing? Hemodiafiltration, I think we achieved the highest level of evidence for everything. I did not mention cost effectiveness, health-related quality of life, outcome. So now what is missing for HDX? We need to know what are the operating conditions. We need to know what are the studies powered to show some, I would say, beneficial effect on the outcome. We need to look on this element. Look the albumin loss and the consequences, because this is something need to be investigated. And then from my side, what is the take-away message? It's very easy. This is a pathway from CKD end-stage patient, technical advancement. So hemodiafiltration, it's on the top. It's almost highest evidence that we have shown in any kidney replacement therapy. And HDX is still on the way. So we are waiting to see different, I would say, long-term study to show the beneficial effect. Thank you very much.
So this is the first debate. We all agree that the patient needs more convection therapy, either the internal filtration by HDX or the hemodiafiltration. It's a constant process. I think all of us need more convection therapy. We agree that this patient could not be continuing only high flux dialysis. We all agree on that. We all agree on that. So you have to choose about the discussion. What do you think about hemodiafiltration or HDX? Who agree on hemodiafiltration? It's not my hand. I'm not raising my hand. I'm saying just raise your hand. On the other way, what is the new player in the field of the convection therapy? As Professor Ayman Karkar say that expanded or HDX therapy, medium cutoff. Who agree on that? Or you don't have still yet experience, so you don't know, but you are still convinced about that. We have two convinced here from Professor Cano. We are convinced by the convince and the modality of HDX. also convinced. For myself, I will not give my opinion. Thank you very much. You raised the debate, but we are going forward. We are on the same page, saying the same language that we need more convection therapy, whatever internal or hemodiafiltration. Thank you very much. And now for the second debate before allowing other friends to say. We have here in the second debate, I am kindly asking Professor Hala Al-Wakil and Professor Yasser Hindi and Professor Ali Taha will introduce them. But these are very short notes about the case. And it's a dilemma really in the ICU. In our case scenario here, we have challenges of doing plasma exchange in ICU. It's not a way of the systemic disease needing therapeutic plasma exchange like anti-GPM or TMA. No, you have a patient in ICU we have plenty of therapies, including medium cutoff, high cutoff, hemodiafiltration, adsorption. But where we are from the plasmapheresis. So we have a very short case scenario. Female patient, 62 years old, 22 years of diabetes that presented with sepsis and extensive cellulitis, edema of both lower limbs, and associated hemodynamic instability with a blood pressure 105/60 millimeter mercury. She was admitted to the ICU with a total leukocytic count of 23,000, neutrophilia, hemoglobin 8.9 gram, and platelet 140, maybe from some sepsis, and started systemic antibiotic and systemic vasopressor and the fluid resuscitations. Her CRP is extremely high, it's 214, and procalcitonin is 12. On the same time, still, the serum creatinine is 1.3 PON 60 from the catabolic state and probably tissue necrosis, and urine output is still maintained on 75 milli per hour without diuretics. So in this case, we are looking for, is there a role of plasma exchange here in this patient, not for additional cause, but for the sepsis itself? Maybe the rationale of removal of harmful substances, including bacterial toxins, BAMs and DAMs, or basic techniques may be not efficient. So a consultation of the nephrologist to start plasma exchange solely for patient with sepsis. Do you agree that to do plasma exchange in this patient, or you don't agree? Who agrees that to start plasma exchange simply for sepsis? No one. And then we have two defense about this approach, Professor Hala and the professor. We can introduce them.
So Hala Al-Wakil will give us the information about one do or not do.
I am with the pro.
I will are not aligned to do or not to do because I need a debate.
Okay. No, I will do. Okay. Thank you very much for the organizer who invited me to deliver this talk, and thank you for the introduction, Mr. Chairman. So I will skip the definition of sepsis and will pass to the pathophysiology of sepsis. We have three biological domains involved in sepsis. We have the immune dysregulation, we have the endothelial activation, and the microvascular dysfunction. We have also the complement activations and coagulation dysfunction. To start with the immune system dysregulation, we have first, we have overstimulation of the innate as well as adaptive immune response, and at the end of the day, we have suppression. These lead to the cytokine storms that lead to the fever, shock, and organ dysfunction, and decreased phagocytosis. Also, at the end with late sepsis, we have apoptotic immune exclusion, namely for the helper cell and expansion of the T reg cells with over immunosuppression. What is more important is the endothelial dysfunction occurring in such cases, which is triggered by the cytokine storm and the active oxygen species, as well as bacterial products, which lead to the overexpression of the Vavani brand, lead to the start of the fibrin clots, which trap platelets. This helped by the consumption of the ADAM13, as well as depression of the anticoagulant with the consumption of the protein S, protein C, and antithrombin 3. All these lead to the some sort of DIC. This helped by the more traps, as well as neutrophilic adhesions and the recruitment, which leads to increased vascular permeability and more procoagulant state. What about the microvascular dysfunction occurring? We have increased nitroxide sensitase, which lead to vasodilation, but unfortunately this vasodilation is heterogeneous, leading to mismatched oxygen delivery to the tissue, and there will be more and more stop flow capillaries leading due to the microthrombosis as well as the leukocyte plugging. The third domain is complement dysfunction. We have overactivation of these complements with the deleterious effects. So at the end of the day, we have confronted with sepsis with very high mortality global-wise, and still we have gaps in the treatment modality in sepsis, and restoring immune balance rather than blocking single inflammatory cascade has emerged as crucial strategy in sepsis management. And this was the rationale for plasma exchange in cases of sepsis. We are aiming to remove injurious targets leading to the immune dysfunction and the coagulation and propermeability that I have just mentioned. And much more importantly, that we are providing the patient with a protective depleted factors in the healthy donor plasma, so as to restore the immune dysfunction and restore the coagulation defects occurring. And for that reason, the ASFA in its last issue that was published in generally in the very early 2023 categorized plasma exchange for sepsis as category 3 with a grade of evidence of 2B. This means that this should be individualized. So in these next few minutes, we have to revise the high quality studies that has been performed in these 3 years, and that was positive with the plasmapheresis. To start with, the sepsis with multiple organ failure, and this was very elegant study based on the MIMIC-4 database, and they involve 60 plasmapheresis patients with 60 very matched conventional or standard of care patients using the propensity score matching, and this was the strength of this study, that all the baseline demographic and clinical characters was matched in these two groups. And the results was marvelous with the plasmapheresis group. There was improvement in the 28 survival and 1-year survival and the in-hospital survival, significantly with the plasmapheresis group in comparison to the standard of care group. And this was associated with improvement of the immune dysfunction as well as the procoagulant state and the platelet count, together with the hemolytic anemia, and these have an impact on the outcome and the improvement of the SOFA score and the significant reduction of the vasopressor dose. The second indication was the sepsis-associated DIC, and this study elegantly showed this finding, and they involve 3 groups, the plasmapheresis group, together with the control group, as well as the heparin group. And this was involved because the anticoagulant used in the TPE group was heparin, and this group was involved so as to exclude heparin as a confounder. And the 3 groups were matched in terms of the baseline clinical and demographic criteria. What was the results? The results was positive with the TPE in terms of increasing the platelet count, improving the procoagulant factors, improving the outcome, as well as decreasing significantly the length of ICU hospitalization, as well as improving the survival. There was also significant reduction of the incidence of AKI and ARDS, and this was associated with a significant reduction of the endothelial markers, namely the von Willebrand and angiopoietin 2. And their conclusion was that the efficacy of TPE is superior to the heparin, in increasing platelet, improving coagulation function, and improving the hospitalization mortality, as well as the incidence of AKI and ARDS, and the possible mechanism is via improving endothelial function. The third indication was in moderate and critical COVID infection, and this meta-analysis gathered all these studies. It was at the start more than 1,400 studies. They end with only 6 high-quality studies, ranging from moderate to critical cases, and there was positive impact of the plasma exchange in terms of improving the mortality. And lastly, the cases of severe septic shock, and it was defined that requiring vasopressor dose of more than 0.4 microgram per kg per minute. And these studies try to answer this question, and they involved 20 TPE group together with and compared with a control standard of care group. There was a significant reduction in the estimated norepinephrine dose in the first 24 hours, and this was associated with a repletion of the depleted factors, namely the antithrombin 3, the protein C and ADAM13, together with the clearance of the disease biomarkers and mediators, namely the procalcitonin, angiopoietin, as well as the von Willebrand. And this results was present in all grades of sepsis, depending on the baseline lactate. It was persistent with all grades of baseline lactate in contrary to the standard of care. And from this study, they conclude that they can use the plasmapheresis when the baseline lactate exceeding 4 millimole per liter. As regards the safety, no safety signals has been encountered in all these studies. So to conclude, the concept of using TPE in sepsis rely both on the removal of injurious factor, probably more importantly on the replacement of the consumed protective factors, and the use of sepsis should be individualized, and sepsis with multiple organ failure, with TME, with critical cases of COVID, and severe septic shock with large norepinephrine dose and high baseline lactate may benefit from TPE, and we need still a large randomized control trial with high quality so as to adequately evaluate the role of TPE in septic shock. And thank you.
Thank you, Professor Hela. You agree that to do plasma exchange simply in septic. So you agree, you believe in that? You believe in that, it's your beliefs. Okay, it's your opinion. I hope that we are all convinced about that. We can have the other side of against. Professor Khaled, just to introduce.
اولا بنشكر دكتور هلا على الريفيو الجميل الحقيقه، يعني بدات تقنعنا ان احنا ممكن نستعملها. بس عايزين نسمع بقى الاستاذ دكتور ياسر هندي هيقول لنا ايه يمكن يغير وجهه نظرنا. اتفضل يا بيه.
You are now in a hard position. Don't worry.
Thank you, Mr. Chairman. Good afternoon, my dear professor and colleague. During the next few minutes, I will try to answer this hard question about. Okay. First, I will start by this review, which is published a couple of months ago about plasmapheresis in general. This review overviews the background of indication, contraindication, and complication of plasmapheresis as a whole. As regard the indication, the Committee of American Society of Apheresis put 3 categories according to the strength of evidence to do plasma. This برضه? Okay. Category 1 included 15 diseases which are strongly accepted to do therapeutic plasma exchange as a model of therapy. The first one was acute inflammatory demyelinating Guillain-Barré syndrome, ANCA-associated RBGN, antiglomerular basement membrane disease, Guppish syndrome, and others. The second one, which is less strength of evidence, started by acute disseminated encephalomyelitis, catastrophic antiphospholipid cryoglobulin. The last category is category 3. I intended to put it like this to search for sepsis and its position in category 3. It is in the seat of 25, the last one, sepsis with multi-organ failure. So as a strength of evidence, it is very weak to do plasma exchange in patients with sepsis and sepsemic shock. Even in contraindication, it occupies the second contraindication, as these patients are known to be coagulopathic and hemodynamically unstable. As regards complication, there is a lot of complication related to the replacement fluid and anticoagulation and vascular access. All this put us in front of a non-simple procedure to do with this critically ill patient. This study, 2024, someone like me want to convince people not to do plasma exchange, and he depend on some points. First point is timing, when to do plasmapheresis in septic patient. As you know, sepsis is a dynamic, unpredictable disease, and there is dysregulation between immune response, including pro and anti-inflammatory phases, which vary in timing and the magnitude between patients. So patients with sepsis are not alike. In addition to this, the effect of replacement of depleted immune regulatory module, such as ADAM13 and angiopoietin-1, are largely unknown. And this put the question when to start plasmapheresis and when to stop. I will skip this figure with my colleague Hala put it. This is as regards the timing to do plasmapheresis. What about the patient selection? The research identified subphenotype of sepsis. Not only does subphenotyping differentiate prognosis, but it identifies distinct function and pathobiological mechanism mediated by specific genotype, genomic and transcriptomic factor. So this subphenotype of sepsis may respond differently to post the initial infectious insult and subsequent immune modulatory therapy. Given this heterogeneity in sepsis and the history of failure of immune modulatory treatment applied to broad group of patients with sepsis, so additional research on biomarker-guided patient selection is vital to demonstrate benefit from therapeutic plasma exchange in sepsis. Still, there is unanswered question about the technique itself. The number of apheresis treatments required. هل هعمل جلسة 2 10؟ The optimal plasma volume. هل هعمل 1 plasma volume, 2, 1.5 plasma volume, and the choice of replacement fluid. هل بدي albumin ولا بدي بلازما علشان replace insensible loss of beneficial factor? كل دي question not well answered up till now. Another safety question is whether therapeutic plasma exchange should be offered to hemodynamically unstable patients, and how to prioritize therapeutic plasma exchange or renal replacement therapy in patients who need post-procedure. The risk of therapy, as we said before, complication of plasma exchange is general, like a vascular access complication and hypotension, but specifically in sepsis, we remove antibodies which with single session of remove about 2/3 of circulating immunoglobulin G, immunoglobulin M and G, because you know that immunoglobulin M, 90% of it circulate freely in the circulation. And this figure show how much plasma exchange depletes this beneficial immunoglobulin. The blue one is the IG, the red one is the IgM. At the end of the 4th session of plasma exchange, the immunoglobulin approached to 0, which is also susceptible to the patient to the development of another infection other than which he is already on. This antibody depletion during critical illness may translate into clinical relevant infection. Study done, 124 patients, done 700 of plasma exchange session, reported around about 50% rate of infectious complication with a higher rate of pneumonia and aggression of sepsis, and this study was done last year. Therapeutic plasma exchange also can remove biological protein like anakinra, which is used as adjunct therapy in management of sepsis. Also, it removes ceftriaxone and antibodies. It is responsible for removal of about 50% of meronym, which is widely used as a treatment of sepsis. So the need doesn't trump evidence. Every well-conducted meta-analysis، الدكتورة هالة أقنعتنا بمجموعة من الستاديز، لكن هي الحقيقة آخر جملة قالتها هي الجملة اللي قالها الراجل اللي بيقول بلاش تعملوا بلازما فريز، وهي إيه؟ In even those reporting possible signal of benefit has concluded that evidence is weak and the additional data are needed. Moreover, short-term benefit can be followed by high-risk development of secondary infection. This study concluded at the end that the high mortality of sepsis compel us to aggressively pursue all promising treatment, so high quality research, but it shouldn't push us to apply unproven therapy outside the clinical trial. All this study reviewed by the previous authors, so we shall not put too much time about it. It is about the safety, timing, and the patient selection, something like that. All of this didn't give conclusive evidence that we have to do plasma exchange in patients with sepsis. Look at this study, 2022. This study comprised 700 patients. 22 patients of this can tolerate plasma exchange. It only represents 3% of patients with sepsis. Even this small number, when compared by patient matched treated by standard care of therapy, they conclude that therapeutic plasma exchange may not be associated with improvement of organ failure, and the mortality in critically ill patients with sepsis, and may be associated with prolonged ICU stay. Even the authors who tried to convince us to do plasma exchange concluded that we have to wait for 2 large-scale multi-center study, one in Europe and one in Canada, and hoping to answer the question, is the removal and replacement of mediator from circulation indeed sufficient to modulate a compartmentalized host defense, host response to infection? And how often and for how long is the exchange of plasma required to improve organ failure and the ultimate outcome? This study done and published last week, February 14, it also concludes that pro-inflammatory cytokines such as TNF, IL-6, IL-8 were significantly reduced post-group of therapy, whether therapeutic plasma exchange or patient received the standard care of therapy. Thank you, Ana خلاص.
Thank you very much.
Okay. كلام ماشي
It's no. It's clear that we have two opposing opinion here, to do or not to do plasma exchange simply. Who are agreed that to do plasma exchange in patient for
دكتور
sepsis?
هشام معلش بعد اذن، هو الموضوع زي ده الحقيقه كان عايز يبقى فيه فوتنج عليه
ما أنا
عشان
عشان كده
نسبة، لا
بس-
كان فوتنج هنا
لا
عشان
لا ما
نشوف رأي
عندناش ما عندناش
الaudience إيه
ما
يعني.
عندناش
حاجه اكسبنسيف جدا فلازم
ما
نسمع.
عندناش فوتنج عشان بس ما نعترضش على المؤتمر. ما عندناش فوتنج، لكن احنا عندنا هنا الاكسبرت اوبينيون. Who accept that to do plasma exchange in patient like that? By Professor. طبعا مين يشهد للعروسه؟ كلامها مقنع. So we still have in this debate.
I think, Dr. Hisham, I think it is not absolute indication or not contraindication. I think
I am talking
Yes.
about my case scenario. So my case scenario, to do or not to do, according to the case,
Yes.
not in general.
Yes to do.
Yes to do. Yes to do. Not to do. Not to do. No need. No need. I presented a case with sepsis induced, no acute kidney injury, CRP highly, cytokines. Yes, according to the case, to do or not to do. Hemodynamic 100, yes, 5, systolic. In this patient, in this case scenario,
Which individual you choose, يا دكتور هاني؟
there is no acute kidney injury. There is acute kidney injury not necessitating renal replacement therapy.
Sepsis without hemoperfusion has a better outcome in treatment of sepsis in intensive care units more than plasmapheresis.
So you agree that you may have another more selective absorption
Another
technique
extracorporeal
rather than the blind technique of removing all the good and the bad molecules and antibodies. We have to do with plasma for Adam T13 and the coagulation and for sure. So still there is debatable, unsolved, and I think this will not be solved.
دكتور هشام، حضرتك في احيانا سيبتك شوك كيسز وبتبقى كليرد من الانفكشن وستيل ريزيستنت للتريتمنت، هل ممكن نستخدم البلازما اكسشينج از اوف ليبل انديكيشن في الحالات اللي زي كده كليرد من الانفكشن وستيل نو ريسبونس؟
And this is the case. Professor Muntasar, Professor Daulat say that you have
I agree.
alternative techniques.
هو
Absorption.
انا هجاوب على
Maybe
الدكتور
or not.
زغلول. هو بالنسبه للثيرابيوتيك اكسشينج في الحالات بتاعه السيبسيس دي، كل ما تبتدي ايرلير كل ما بيكون احسن، لان انت بتبتدي ايرلير في الستيج اوف هايبر انفلاميشن، لكن بعد كده بيبقى في انتي انفلاماتوري ريسبونس. انت هتديبرايف البيشنت دوت من البينيفيشال افكت بتاع الانتي انفلاماتوري ريسبونس، فانت ما بتقدرش تحدد الاوتكم بتاع البيشنت ده قد ايه، وهي دي المشكله. ابتدي بدري ولا استنى؟ ولو استنيت
It's in the start, it's a balance between inflammatory and anti-inflammatory cytokines. If you have more inflammatory cytokines, there is an inflammatory spike or storm. So at the start, you have moderate inflammatory and anti-inflammatory in the balanced way. But if you have more inflammatory, you go to the cytokine storm. And this, at this point, hemodynamically, may be not good. In all case, I think at this stage, patient will have acute kidney injury and may get benefits from additional like auxiliaries or others. We will talk about that in this third scenario. Thank you very much. We appreciate your opinion.
Thank you.
And your conveyance for the audience. Now coming to the third one and still unsolved problem. So in this debate, I cannot go to the right or to the left, and I'm still waiting in the middle between two professors. Let us have this case scenario, PERT versus CRRT. And we have here in the speaker, here one of the experts. Our case scenario saying that male patient 62 years old with diabetes for 20 years and hypertension on amlodipine and losartan. His baseline lab results were as following, with creatinine 1.1, hemoglobin A1C was 8%, and urinary albumin creatinine ratio is 300 milligram per gram. His nephrologist in the last months before presenting to the ER prescribed dapagliflozin 10 milligram per day beside his above medication. He is obese with a body mass index 42, and he was presented with fever, hypotension, and hypoxemic respiratory failure secondary to pneumonia. And this is the CT scan finding. On examination, he was intubated, sedated, and on mechanical ventilation, a blood pressure 90/60 without significant support at this moment, and with bronchodilators, furosemide infusion 20 milligram per day, and the blood pressure is around 170 millimeter with a vasopressor for systemic support later on. So starting 90/60 with vasopressor is 110/70. Urine output of the previous 24 hours was only 300 milli per day, and further lab results showing that blood urea nitrogen jumped to 70 and creatinine up to 5.2. Electrolyte is good, except for potassium is 6.7 with normonatremic. Chlorine bicarbonate is acidotic with 16 milliequivalent. There is no available data for more. However, his lactic acidosis is 1.6. The CBC showing total leukocytic count 22%, thousands. And urine analysis, 2 plus proteins, 1 plus blood, and more than 60 high power filled red blood cells. So we have here in a patient with ICU an every hour they practice with life-threatening complications of AKI, and we cannot have a watching, waiting profiling. We have to need to do a renal replacement therapy in these patients for volume, sepsis, and acute kidney injury. So what about the decisions in these particular patients from the nephrologist's point to start renal replacement therapy? So what do you recommend to start? Which type of renal replacement therapy in these patients? He has no additional brain injury and hemodynamically support. PERT or CRRT? I don't know the answer, but we'll give you that in the voting by the experts here, Professor Yasser and Professor Muntasir, and I will keep Mustafa to just kindly introduce our colleagues here.
Now to this debate, I would like to introduce Professor Dr. Muntasir Zaid, Professor for Internal Medicine and Nephrology at Alexandria University. تفضل دكتور منتصر.
Thank you, Mr. President, for the nice introduction. I will start by PERT. Acute kidney injury in the intensive care unit is common. Depending on definition, up to 50 to 60% of patients in the intensive care have acute kidney injury, and up to 70% of these will require renal replacement therapy, and mortality is high, more than 50 to 60% in intensive care units. And this figure shows that mortality by acute kidney injury is more than 50% for patients requiring renal replacement therapy, and less than 10% for patients not suffering from acute kidney injury or on renal replacement therapy, and about 30% for patients with acute kidney injury not requiring renal replacement therapy. As regards major renal replacement therapy techniques, we have intermittent hemodialysis and intermittent ultrafiltration, continuous renal replacement therapy, CVVH, CVVHD, CVVH hemodiafiltration, and SCAF, slow continuous ultrafiltration, and the hybrid techniques as slow extended daily dialysis. So the hybrid strategies seek a middle ground between CRRT and the standard intermittent hemodialysis. To differentiate between the different types of renal replacement therapy, for continuous renal replacement therapy, the blood flow rate is around from 100 to 300 milli per minute, and for intermittent hemodialysis above 400 milli per minute, and in between the prolonged intermittent renal replacement therapy in the range from 200 to 300 milli per minute. And for continuous renal replacement therapy, the dialysate flow is 20 to 25 milli per kg per hour, maybe up to 45 milli per kg for high volume septic patients. And this amount is that for dialysate fluid and replacement solution. And dialysate flow for prolonged intermittent hemodialysis is in the range of about 200 milli per minute, and for hemodialysis above 500 milli per minute. As regards ultrafiltration rate, up to 200 milli per hour for continuous renal replacement therapy, prolonged intermittent renal replacement therapy up to 400 milli per hour, and for intermittent hemodialysis up to 1 liter per hour. The duration, of course, as it is a continuous renal replacement therapy, 24 hours per day, and for prolonged intermittent renal replacement therapy, 8 to 12 hours, and for intermittent hemodialysis, as we all know, up to 4 hours. And the frequency, 7 days per week, and 4 to 7 days per week for prolonged intermittent renal replacement therapy, and 3 days per week for intermittent hemodialysis. A prospective randomized controlled trial for the effect of continuous versus intermittent renal replacement therapy on the outcome of critically ill patients with acute renal failure, the CONVENT study. 252 critically ill patients with dialysis-dependent acute renal failure. Patients were randomized to receive either daily intermittent hemodialysis or continuous venous hemofiltration, and the primary outcome measure was survival at 14 days, and secondary outcome survival at 30 days, ICU and intra-hospital mortality, as well as course of disease severity, biomarkers, and the need for organ support. The results showed that, or they concluded that no statistically significant difference was observed between the treatment modalities regarding mortality, renal-related outcome measures, or survival at 14 days after renal replacement therapy. What is pro-intermittent renal replacement therapy? It is practical, flexible, uses the same machine as chronic hemodialysis, multiple patients per day, easy to mobilize patients, less expensive than CRRT, and fewer bleeding complications as CRRT requires continuous anticoagulation, less filter clotting, and superior solute clearance, and more rapid removal of toxins. Specific patient population benefiting from prolonged intermittent renal replacement therapy, high bleeding risk, and acute treatment of hyperkalemia, rhabdomyolysis, poisoning, tumor lysis syndrome, and acute pulmonary edema. As regards nursing model for continuous renal replacement therapy, we may require one-on-one ICU nurse, and for birth, we may need one nurse for 2 sessions of prolonged intermittent renal replacement therapy, and for intermittent hemodialysis, 4 patients to each nurse. A systematic review and the network meta-analysis comparing renal replacement therapy modalities in critically ill patients with acute kidney injury. As regards mortality, continuous renal replacement therapy showed no different from intermittent hemodialysis in terms of effect on mortality, and demonstrated a possible increase in mortality compared with SLED. And this results from 19 studies examining about 2,576 patients. As you see in this table, the first one, continuous renal replacement therapy versus intermittent hemodialysis, the summary is that the results is that there may be no important difference. Also, CRRT versus SLED, CRRT may increase mortality compared with SLED. As regards renal recovery rate, the results suggest that CRRT may increase renal recovery compared with intermittent hemodialysis, whereas both CRRT and intermittent hemodialysis may be worse for renal recovery compared with SLIT. As regards hospital stays, the primary analysis for length of ICU, 11 trials and 1,785 patients, and the results suggested that CRRT and intermittent hemodialysis may increase ICU length of stay compared with SLIT. And this systematic review and meta-analysis assessing different modalities of renal replacement therapy in critically ill patients showed that no difference in mortality between CRRT and intermittent hemodialysis. CRRT was found to increase renal recovery compared with intermittent hemodialysis. And at the very least, ICU clinicians should feel comfortable that the differences between CRRT, intermittent hemodialysis, slow efficiency, extended dialysis, and where clinically appropriate peritoneal dialysis are likely small, and any of these modalities is a reasonable option to employ in critically ill patients. Another meta-analysis and systematic review, their authors concluded that neither of the two techniques is superior to the other in risk of mortality in ICU or hospital, length of stay in hospital, recovery of renal function, or furthermore, a greater tendency for filter coagulation is evidenced in those treated with continuous renal replacement therapy. As regards cost, which is very important, and you have to put in mind, the median difference in price was in US dollars, 289 per day, which did not favor CRRT over intermittent hemodialysis. And in Egypt, it costs about 50,000 Egyptian pounds per day compared to 685 Egyptian pounds for intermittent hemodialysis. Back to guidelines, the French Intensive Care Society concluded that continuous and intermittent renal replacement therapy techniques can be used equally, taking into account their availability and the experience of the team, and this is strong agreement. As regards KDIGO guidelines for acute kidney injury 2012, they said that use continuous and intermittent renal replacement therapy as complementary therapy in patients with acute kidney injury, and they suggest that CRRT rather than standard intermittent renal replacement therapy for hemodynamically unstable patients. But maybe at that time of 2012, the information and data about birth was scarce, and so this recommendation may change according to the recent data. Mr. Chairman, dear colleagues, to summarize, maybe it's time to say goodbye to any more. Just 1 minute.
1 minute, please.
Maybe it's time to say goodbye to any more CRRT, high dose versus low dose, CRRT versus intermittent hemodialysis trials, because hundreds of studies, including multi-center randomized controlled trials, meta-analysis, have not shown a clear benefit of one over the other. The choice of renal replacement therapy in critically ill patients is best left to the clinicians handling these patients, depending on the condition of patients, infrastructure, expertise, and funds available in a given situation. Whatever treatment is used, use it at its best performance. Be flexible and try to prescribe the right therapy to the right patient. Be ready to cross over from one modality to another, and make sure you are not under-dialyzing your patient, and the ideal study will never be done. Thank you.
Thank you, Dr. Muntazir. Many thanks. حقيقي انت اوجزت في اخر conclusion of summary of this session. According to infrastructure, according to visibility, according to accommodation, according to education, according to anything. احنا لازم نكون مختارين العيان ونفصل عليه هنعمل ايه. هنسمع بقى Now, in other sides, I would like to introduce Professor Dr. Yas Abdul Hamid, Professor of Nephrology and Internal Medicine, Cairo University, to continue this debate. CRRT or PERET.
Bismillah ar-Rahman ar-Rahim. I would like to thank and congratulate Egyptian Society of Nephrology and Transplantation for this very highly successful Congress. And I think I was put in a narrow corner for defending such a modality all do not like usually to use. I would like to defend CCRT. So for me, for a modality to be better, I think it should have more advantages and should have its special circumstances to be used in, and it should be logically convincing for all. So let me go for the advantages of CRRT. The main advantage is hemodynamic stability, followed by less effect on, say, intracranial pressure, better and smooth volume control of body temperature, solute control better, especially sodium and dysnatremias, and ICU nutrition, allowing for better ICU nutrition. Let we agree that hemodynamic stability of critically ill patient is the main determinant of choice of the dialysis modality. If we look to the previous slide, we will find that hemodynamic stability is the first one of advantages of CRRT. So its advantage is mainly likely the one that guarantee how to choose the modality. These are the how to volume hemodynamic stability during intermittent hemodialysis in comparison to CVVHD, and you can see that mean arterial blood pressure baseline is higher with intermittent in pre-dialysis and intradialysis. You can see that even with lower pre-dialysis levels in CRRT, maintenance or even higher levels on dialysis with CRRT of mean arterial blood pressure. So better hemodynamic stability. Why do this occur? Maintenance of intravascular compartment volume. Of course, prolonged treatment permits lower fluid rates, and please, you can calculate this formula, how much fluid do you remove per minute. Urea diffusion is known to be faster with intermittent hemodialysis than CRRT. Convective sodium removal rate is less effusive than the diffusion removal rate that hemodialysis depends. Better control of core temperature with fluctuation on hemodynamics and removal of inflammatory mediators, tackling the original cause of the disease. What's about clearance? You know all the two methods of clearance, diffusion or ultrafiltration. And by diffusion, you can only that hemodialysis depends without the combination of HDF, simple hemodialysis, or intermittent forms or PERET. It's removal of small molecules by only diffusion clearance. When we add convection, hemofiltration, you can jump up to molecules such as beta-2 microglobulin or potassium light chains. So CKRT or continuous kidney replacement therapy contains both methods of clearance, which is convection of and diffusion, comparing with PERET using only the diffusion method. These are criteria of different therapies, and you can see this is intermittent forms of dialysis, and this is the forms of CRRT, nearly similar diffusion and or maybe somewhat higher due to addition of convection in CRRT. And you can see better volume control, of course, with CRRT. And this is the volume control, mean percent fluid accumulation with intermittent hemodialysis, more and more fluid accumulation in this study in CJSN, while CRRT slower, lower down the fluid removal. And these are mean fluid accumulation, intermittent hemodialysis with days, and you can see more fluid accumulation, again lower, but CRRT progressively lower with session, so better fluid control over time. And this is gradual solute control. The red one is for intermittent daily hemodialysis or daily PERET. You can see that the jump or the peak and rebound phenomena regarding body weight control, mean arterial blood pressure, blood urea nitrogen, and bicarbonate. On the other hand, you can observe that the blue dotted line for CVVH can smooth control for all of these criteria, smooth lower body weight, smooth PON, and CVVH and bicarbonate. The second one is our modality CRRT can be used in special circumstances or has its own special circumstances to be used in. I think the answer is yes. And Professor Montasser facilitated this job for me and illustrated for you some of these indications. Intracranial hypertension, of course, gradual correction of severe dysnatremias, hyper and hyponatremia, cardiopulmonary failure requiring ECMO or other mechanical circulation, organ support in patients with advanced heart or liver disease unable to tolerate, intermittent hemodialysis and condition requiring continuous solute removal such as rhabdomyolysis. And if I remember the case Professor Hisham illustrated a few minutes ago, it had a CK of 3,000 suspicious of something like this. So if we can stick to this indication or this specific indication, we can use CKRT in this condition. Single hemodialysis session regarding control of brain edema could lead to an increase in brain tissue volume during the session, accompanied by alteration in white matter volume, diffusion metrics, and brain volume was found to be changed. Brain metabolite concentration similar to or consistent with ischemic injury. What are the hemodialysis CNS complications we are all aware about? These include dialysis equilibrium syndrome, with each known due to rapid removal of urea, paradoxical intracellular acidosis that leads to normal neuronal swellings and cerebral edema, and intradiuretic hypotension, which may itself lead to decreased intracranial pressure. So, in the view of one modality that has a good effect on brain metabolism and brain intracranial pressure, we have another modality that had its specific side effects regarding brain. And this is the effect of intracranial pressure. You can see that intracranial pressure, CVVH, using CVVH-DF, is maintained with no changes, or even might be somewhat lower, but these are increase of intracranial pressure with the use of intermittent hemodialysis and with rebound down. And this is the fall in serum osmolarity with the rapid removal of urea and solutes with intermittent hemodialysis, much, much more higher than CVVH in the view of comparison to intermittent hemodialysis, which leads to, of course, development of brain edema. So non-renal indications include hemodynamic instability, acute brain injury, decreased cerebral edema, and acute fulminant liver failure, which I will not go throughout, but please know. And in this case, we can use especially in specific circumstances containing combined both acute renal and hepatic failure. What about sepsis? Many studies, initially RONCO, high volume hemofiltration on 3 groups offered no benefits regarding mortality. While ivory meta-analysis evaluating more studies suggested also that no benefits over mortality over hemodialysis with regarding mortality. Later on, the use of high dose up to 80 milliliter per kg per hour found to have decreased interleukin and interleukin 6, 8, and 10, and no effect on mortality compared to conventional doses of 40, which is usually higher than the recommended doses. So we have no effect on the mortality, but there is sure effect or on the decrease of cytokines. Of course, I know that it is the harmful and the beneficial cytokines, but there is decrease of cytokines, maybe due to decreased number of studies or decreased number of patients in studies. Many studies reach to the same results, resulting that we cannot reach to a conclusion in this point. We have decrease, but we have no long-term effect. These are membranes used in sepsis, topomyosin membrane, cytosorb or oxoris membranes, many membranes, and found reduction of these cytokines, all, and the mortality in these studies found to be significantly reduced in this meeting with 2012. And these membranes, and sorry. And this is the cytosorb fixed on the column. And regarding severe dynasteremia, and this is the safety effectiveness of low dialysate sodium was studied by the National Kidney Foundation, and they recommended the use of low sodium dialysate as a feasible and safe strategy for correction of hyponatremia. In CRRT, we have 2 methods of correction of sodium regarding dysnatremia. We can use the dialysate composition, which can carries the risk of more hyponatremia, but using D5 after on the effluent. Or we can prepare our solutions with sodium and different sodium concentrations according to serum sodium and CRRT removal. And if use the one, please, these are the formulas to use. CRRT, can I have?
2 minutes, please. IT, 2 minutes, please.
1 minute. These are the formulas to use to calculate for CRRT, how much sodium, how much volume to add, and how much volume to exchange to reach your proper sodium correction. And if we use the second line, we are to use this formula to calculate D5 rate of infusion. What about renal recovery? Professor Muntasser said this is a meta-analysis in 2020. And they stated that urine output at CRRT discontinuation, lower initial SOFA score, and lower serum creatinine level at CRRT initiation were all associated with likelihood of renal recovery. So if you speak about renal recovery, these are the factors that guarantee the effect on renal recovery. The third one is that our modality should be logically convincing. Look please at this slide. PERET is called prolonged intermittent renal replacement therapy, while CRRT is continuous renal replacement therapy. If we remove the similars, we felt with prolonged intermittent or continuous. Let me ask you a question. Our kidney's job, is it intermittent or continuous? I think the answer is well known. So our modality is logically convincing, it is similar to the kidney. It is not that white, it is not that shining, it has many disadvantages, such as it is not continuous. Usually a patient go to CT, something like this, or care, use of anticoagulation, bed rest, higher cost, lower efficiency than intermittent hemodialysis, and risk of temperature changes. And ongoing controversies in CRRT proposed by Karkar and Ronco, the optimal approaches to volume management and net ultrafiltration in CKRT, strategies for optimal discontinuation, when to discontinue and when to start, optimal dosing, what to do with obesity, safe lower dose limits, dosing of other solutes, phosphate lowering, and tunnel catheter. And thank you very much. And this is my conclusion. It needs to be promoted in our country. It is a modality similar and needs to be promoted in our country. Thank you so much.